Thank you very much. It's a pleasure for me to be here today, and what I want to tell you a little bit about in this session is the challenges that we all face now managing patients with hepatocellular carcinoma when it arises on the background of the metabolic syndrome and often NASH. So this is what's happening. This is data from a review published in 2015 looking at the cancer mortality trends for liver cancer in the US. And what you can see there is that in that time period, for the majority of cancer types, the mortality was falling, but that was in sharp contrast to liver cancer patients here, where you can see that there was a dramatic increase. And we've got some more recent data for Europe. This is data from Cancer Research UK, looking at the most common causes of cancer death over a 2-year period, the first one being 2003 to 2005, and then comparing that to a 2-year period between 2012 and 2014. And again, what you can see is that you've got falling incidences and causes of mortality for the majority of cancer types. But again, liver cancer really leading the way is the one that's out there causing death where we're not having very much impact. And this is also data from Cancer Research UK, and it's focusing on the UK. And this is the predicted increase in liver cancer incidence that we're expecting to see. And this is, you probably can't see it, but that's 2035. And this is where we are at the moment. And the dotted line is what we're predicting is going to happen over the next 15 to 20 years. So as yet, this increase that we're seeing in liver cancer incidence and mortality doesn't show any sign of abating. Now, historically, the increase in liver cancer has been attributed to hepatitis, viral hepatitis B, hepatitis C, and alcohol. But we're all now very familiar with maps like this. This is a global map showing us the areas in the world where you have a raised BMI. This cutoff here is quite low, it's 25, but the darker the color for your country, that's the percentage of people in your country who have a raised BMI. And if we look at Europe, a slightly different kind of a map here, but we're looking at the percentages. This time it's actually people that are classed as obese. So WHO data from 2017 looking at the percentage population with a BMI greater than 30. Nothing to be proud of, but the UK seems to be leading the way here with nearly a third of people in the UK actually being obese. Some countries in Europe not quite as bad. You can see southern countries, Italy, not such a high prevalence of obesity. Now, I'll just talk you through this slide because it's quite busy, but what we're looking at here are the trends in the incidence of liver cancer in different areas of Europe over the last 20 to 30 years. So this is Southern European countries, and along the bottom here, we're looking at a time period from 1980, and this is up until 2010. Italy shown in the green bars here, and so the sharp increase seen in the 80s and 90s attributed to hepatitis C. So Italy really having the highest incidence of mortality attributed to liver cancer in Europe for some time. Similar data for Spain, Austria here rising a little bit more, but also having quite a high incidence in Western Europe. And then in the Northern European countries, so here we've got countries that have traditionally had a very low prevalence of viral hepatitis C. The UK in particular, very low in the 1980s. But you see this very, very sharp increase over the last 20 years, so that now, despite not having an increase in the prevalence of hepatitis C, we're sort of reaching similar levels to the incidence of hepatocellular cancer that's seen in places like Italy and Spain. So is this all because of obesity and non-alcoholic fatty liver disease? And this is data from my own unit in the north of England in Newcastle upon Tyne. And this is looking at the numbers of cases referred to our multidisciplinary meeting. Now, in 2000, we didn't have a multidisciplinary meeting, and the patients with liver cancer tended to stay in their regional centre and die there because there wasn't treatments for them. But that changed after that because NHS England thought this was unfair, there was unequal healthcare in the UK, and so there was a mandate that you had to refer your patient to a tertiary centre whether or not there was a treatment to give them. So although we didn't really have the treatments what we did have is the opportunity to study what was happening in our region and the underlying etiologies associated with liver cancer. So green here is alcohol. We can't deny that alcohol is a big cause of liver cancer in the north of England. The purple bar, this dark bar, that's hepatitis C, so fairly steady really over the last 10 to 15 years. And then coming from nowhere is this orange bar, and that is obesity-associated liver disease, liver cancer attributed to NAFLD, where we've actually proven they've got NAFLD either on imaging or on a biopsy, and they don't have another cause of chronic liver disease. So there's no doubt that it is the commonest cause of liver cancer in the north of England. Now, this is actually looking at the same data set, but stopping at 2010 here, and breaking the patients down based on the stage of their disease when they present. So this is the Barcelona Clinic for Liver Cancer Staging System, where A is patients with early disease that you might cure with resection, transplant, or ablation. B are the intermediate stage disease patients who'll be having local regional therapies. C, these are patients with advanced tumours, portal vein thrombosis, extrahepatic disease, or possibly a deteriorating performance status comorbidity that puts them in that category where you can't offer them anything other than palliative treatments. And the BCLC-D patients, those are the ones where you can't offer them anything because they're not fit enough or their cancer is just too advanced. So the problem you can see here is that the majority of the patients that we've seen over that time period have presented with advanced disease. And this dark line, that's the mortality in our region. So the difference between this line here and the white line, which is the mortality from the patients referred to us, is that all these patients died in their referring centre without being sent to us. We created this MDT, all the patients were referred, and we had no impact on mortality because they all died after they were referred. And that's because of the stage of their disease. Now, if we focus in on those patients with NAFLD, what can I tell you about them? Well, first of all, they're older. Their median age was 70. The median age of the viral hepatitis patients was 60, and for alcohol, it was 64. The patients are presenting at an older age, perhaps because the development of the disease is different, but also they're not in surveillance programs, so we're not looking for the cancers. We don't find them earlier. So that's why 70% of these patients present with advanced disease. And their survival isn't actually determined by their age, it's determined by the stage or the fact they've got NAFLD. It is determined by the stage of their disease. And the BCLC algorithm is a very good prognostic model, even in NAFLD patients. There's this other feature that we have to remember, and that's that up to a quarter of the patients with NAFLD, they don't actually develop liver cancer on a background of cirrhosis. So there's the opportunity here in patients with preserved liver function that if we found their disease early enough, their liver might be fit enough for us to be able to intervene with aggressive therapies. But we have to be careful with that because these patients are older still than the ones developing liver cancer on a background of cirrhosis. It takes longer, so their median age is 72 in our centre. So that's a little bit about the background of the histology of the liver and how that might influence our practice. But what do we know about the histology of the tumours? So this is the WHO classification, trabecular, acinar, solid and serous tumours. We don't think that there's any particular reason that they would progress differently in patients with NAFLD. But there are two new types of tumours now reported. This is the combined hepatocellular cholangiocarcinoma. This may be more common in patients with the metabolic syndrome. This is still an emerging field. And there's a suggestion that these patients do badly, whatever their underlying etiology, compared to the non-mixed hepatocellular carcinomas. And then there's this type of cancer, very fatty cancer, the steatohepatic hepatocellular cancer, and that definitely appears to be more common in patients with NAFLD or the metabolic syndrome. And we don't know the natural history or progression of this type of cancer yet, but there's a suggestion that perhaps it progresses less aggressively. So there might be some value in knowing more about the histology of these tumors when deciding whether to treat a patient or not, never mind what treatment to give them. But then we come to the algorithm that we all use for managing our patients, the Barcelona Clinic for Liver Cancer algorithm, used for prognosis determination, but also for guiding us into what's the right treatment for our patient. Should it be surgery, resection, ablation, transplantation for patients with early stage disease? Should it be medical therapy for advanced stage or local regional therapies? The problem is that many of our patients don't have cirrhosis for a start. So is this algorithm actually relevant for them at all? And then when you look at the evidence base for this algorithm, this is the typical stage of the patients that present to the BCLC. You would expect 30% to have early stage disease, 20% to have intermediate stage disease, 40% to be in advanced stage disease, and only 10% to have this terminal stage disease. So there you've got an algorithm that works for you for the majority of your patients that you're seeing. But the problem for us is that it's not the same for the NAFLD HCC patients. 30% have terminal stage disease, 10% only have got early stage disease, 15% intermediate, and the vast majority of treatable patients for us fall into this single category where there's just one line which suggests that it's medical therapy or nothing. And for these patients, if the treatment you have on offer is sorafenib, and they're patients that might have comorbidities associated with metabolic syndrome, they might have renal impairment, a previous cardiovascular history, sorafenib's not the ideal therapy, but it's the only thing there on the table. And we don't really know whether we should be treating these patients differently with other therapies in some instances. So there might be other staging systems. People have looked at the ALBI score. There's also the Hong Kong classification for liver cancer, which is perhaps a little bit more aggressive in terms of surgery for patients that don't have cirrhosis. But nothing like that's actually been validated, certainly not prospectively in patients with NAFLD. So I want to spend a little bit of time here just going through the pathway that we use in Newcastle for managing our patients, where, as I've said, nearly 40 or 50% of them have NAFLD HCC, and actually 70% of our patients have the metabolic syndrome, whether or not that's the primary cause of their liver cancer. So this is what we do. It's not particularly evidence-based. Where I've put a little star, these are areas where research is required before you could ever make a guideline. But here's the patient that comes to us with suspected HCC, where they're managed within a multidisciplinary team. And now we've got the patients that we know have got cirrhosis, either on biopsy or on their imaging. And if they have an HCC that's typical on imaging as per the EASL guidelines, we're going to manage them as per the BCLC algorithm. The proviso there is that for all of those patients that are lumped into the BCLC category, where you're going to decide whether they're fit enough for sorafenib or not, there will be patients who are just not fit enough that you're going to manage with supportive care. But there may be patients, and actually it's up to 20%, where you have a small cancer with preserved liver function. They have no portal vein thrombosis or extrahepatic disease, and they're in that category because of their performance status, which might be that they're lethargic for another reason, not necessarily cancer-related. And it's very difficult to unpick performance and fitness when you have other things that might be contributing. So for those patients, we might, rather than just refer them for supportive care, we might monitor them for 3 months, check their liver function, check that their performance function is stable, and then monitor their tumor. So if their small cancer is one that's growing rapidly, their alpha-fetoprotein is rising, but they're otherwise fit and their liver function is good, we might actually consider local regional therapy in those patients. If you think they're going to die of their liver cancer, and if you didn't treat their cancer, they would live for a few more years. But that's something that needs to be validated prospectively. But what about all the other patients, 30 to 40% that don't have obvious cirrhosis when they present to us? So these are patients that when you see them, you need to decide, are they fit enough to have treatment? Because if they're not, there's no point biopsying them. But if you think they might be, you're going to biopsy their tumor and their non-tumor liver. If they've got cirrhosis, they're going to come back into this side of the pathway. If they don't have cirrhosis, this is where we're outside of the algorithm, and all the centers here that manage patients with liver cancer, everybody's doing their own thing and really learning by experience as more of these patients come along. So in our multidisciplinary meeting, we will discuss this patient who doesn't have cirrhosis on the basis of really their tumor node metastasis stage. Have they got bilobar disease? How big are their tumors? There'll be an anesthetic assessment for these patients. And in our center, cardiopulmonary exercise testing is a very important assessment of their cardiovascular and respiratory fitness before you're going to think about a resection. And so if these patients are just thought not fit enough or the disease too advanced, they're going to go back into this side of the algorithm. But otherwise, we would be hoping to offer them a resection, even if they have more than one tumor, possibly even if they only have, if they have a large tumor and just one small lesion in the left lobe, perhaps, in combination with SERT to downstage, possibly with ablation. And whilst we're doing these things to these patients, always we're trying, without any evidence, to advise them to live a healthier lifestyle, believing that if they exercise a little bit, they'll be fit enough or fitter to have that resection. But again, this is something else that we don't know very much about, where we need to do some more clinical research. So to summarize this, the challenge of liver cancer and NAFLD, there's a need to address metabolic risks just because of the progression of NAFLD and the development of HCC. These patients that present with cancers, they're older, they have comorbidities. These patients are not well represented in the evidence base for the EASL clinical practice guidelines. They're not well represented either in clinical trials of the newer therapies that are emerging, although there is some data. These patients, they're often too old for a transplant, because we tend not to transplant patients over 70 in our institution. That's not a strict rule, but in other institutions, it's less than that. They might be unfit for resection. Systemic therapy, there is some data, but you have to be careful because of their comorbidities. Perhaps targeted local regional therapies for patients that have got small volume disease, even if you might class them as BCLCC, might be better. Maybe we should be using some of them in some of these patients. And presently, the performance status that's so key to this algorithm is just something that we don't assess objectively very well in patients with the metabolic syndrome. And then the final point here to make is that obesity is now a disease of childhood. So although at the moment the patients that we're treating are 70, 72, some of them older than that, resections at 78 or even 80. This is going to change. The age of presentation of patients with NAFLD HCC is very likely to fall as the onset of the disease that causes it occurs so much earlier. So this is my final slide, the liver cancer group in Newcastle, and that I couldn't do any of this work without Professor Derek Mannis. He was back in the 90s when liver cancer incidence was so low, trained in South Africa. He was there looking after all of these patients really on his own, without very much of a team interested in liver cancer. This now is the team that we head up in Newcastle, clinical people, and very, very important, but also all the researchers and the PhD students that are working with us now in Newcastle, that NAFLD HCC has become such an important topic. Thank you.
Thank you, Professor Reeves. It's a nice talk. I mean, do we have any burning questions? Otherwise, I would like, together with my chair, to leave all the discussions for the very end of this session, unless someone wants to ask something very hot. No. Thank you, Helen, again.